But I really want to welcome everybody to today's event. If you don't know me, I'm Martell Teasley, Dean of the University of Utah College of Social Work. For those of you who have joined us for our virtual webinars in the past, welcome back. To those joining us for the first time, we are glad to have you. We hope all of you return in the future for virtual events we're offering throughout this summer and beyond. Today's Quarant Talks with Teasley continues to showcase how social work and our talented faculty in particular address critical challenges we face as individuals, professionals, and communities. We are proud to offer today's event supporting the unique needs of seniors experiencing homelessness, presented by University of Utah College of Social Work and College of Architecture and Planning Associate Professor Sarah Canham. Dr. Canham earned her doctorate in gerontology from the University of Maryland in Baltimore County in 2014. Her research interests focus on the social determinants of health, environments and aging, health and social services, homelessness, mental health, and many interconnected issues. Her research interest makes an ideal colleague for the dual appointment with architecture and planning and her additional responsibilities as the Associate Director of Interprofessional Education at the University of Utah. Dr. Canham has received numerous grants for her work. Most recently, she was awarded a $1.3 million grant from the Social Sciences and Humanities Research Council of Canada for her project entitled Aging in the Right Place, Building Capacity for Promising Practices that Support Older People Experiencing Homelessness in Montreal, Calgary, and Vancouver. We are delighted to have Dr. Canham with us today and look forward to her insightful report on this critical matter. Before turning this over to Sarah, I would like to quickly mention some of the important things happening at the college and the university. As you may know, Quarant Talks with Teasley is the virtual webinar series that emerged from our in-person Talks with Teasley events that began in fall 2019. We intend to offer these events and the accompanying free CEUs throughout the summer, as I stated before. We hope these events serve our community well, and we would welcome any suggestions you may have for topics of interest for future webinars. Now, don't email me, email Lisa or Emily Bring on that. No, you can't email me, I'm just kidding. As the college and as the campus, we are also taking action to address what President Ruth Watkins aptly spoke of as systemic racism and oppression brought to the forefront by Black Lives Matters and others. In our efforts to truly make the U a place of hope and change, our administration has initiated the George Floyd Memorial Fund in the Black Cultural Center on campus. The Alumni Association has planned a conversation on race and racism that I will co-lead with the College of Law Dean Elizabeth Crump Warner on June 29th. So please look for information on that. Dr. David Darasotis, one of our senior faculty members in the College of Social Work, has also led conversations on race and equity throughout the Binion Center. And he is a guest on the upcoming episode of President Watkins' podcast. Our college interaction blog features a reading guide for the first time, as well as my message to our students on race and racial justice. And plans are in the works to talk with the Salt Lake City Police Department and their embedded social work team to find solutions to reforms that will save lives. We hope you will join us for these events, as well as for our future Quarant Talks with Teasley, particularly on July 9th and July 23rd. As I always like to say, we are on the move. And now for today's guest of honor, Dr. Sarah Canham. In addition to her outstanding research and teaching talents, Sarah has established herself as a person who builds strong and meaningful relationships with service providers, with people who have lived experiences of homelessness, with older community members who want to contribute to research that serves others. As a recent transplant from Vancouver, British Columbia, Sarah spent time pre-Quarant soaking up the Utah sun and exploring some of Salt Lake City's, that is, amazing restaurants. I remember talking to Sarah right before she left. I think she got back or went back to Vancouver right before a physical distancing started. So Sarah, good to see you today, as I've said, and we'll see you in the fall. Without further ado, though, I offer this virtual stage to Dr. Sarah Canham. Take care, friends.
Thank you, Dean Teasley. I want to share my PowerPoint. Thank you, Dean Teasley, for the very generous introduction, for your leadership at this very critical time on issues of racial justice and the important work that you're doing in the college and the community. It's really important to everything that we're doing, and as we'll talk about today, really important to the work that I do in homelessness and housing insecurity. As is customary in the region where I'm engaged in research, I wanted to make an acknowledgement and start my webinar off today, make an acknowledgement that the research that I'll share with you today was conducted on the unceded territory of the Coast Salish peoples that include the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations, where I am very grateful to be able to engage in this research. As well as I feel also a responsibility to acknowledge that the land of the University of Utah, the land that it occupies, has always been indigenous lands and recognizes the deep history of these peoples, as well as the enduring relationship that exists between indigenous peoples and their traditional territories. And I'm deeply grateful that the indigenous peoples in Utah persevered to protect this land for future generations. The erasure of the relationship between the peoples and their traditional homelands is an insidious form of ongoing colonization. And this is something that we need to be mindful of, as it has a continuing impact on people. And this is particularly important, I feel, in the work that I do around homelessness and housing insecurity, which really forefronts, excuse me, housing as a racial justice issue, and thinking about the importance of an individual's right to housing and to safe and secure locations. I would also like to acknowledge the funding agencies that have generously supported my work, and as Dean Teasley mentioned, also to the numerous community collaborators and persons who who shared their lived experiences with me, which have informed the work that I do. As a quick note, if you have questions as I go through the presentation, please use the Q&A feature, and we'll monitor those, and we'll have a Q&A opportunity at the end. I'll be speaking here for probably about 35, 40 minutes. So an individual, when we look at what it means to be homeless in the United States, this is a definition that's put out by the Department of Housing and Urban Development and their definition of homelessness. And they have 4 categories of what it means to be homeless. This can be an individual or family who lacks a fixed, regular, and adequate nighttime residence, which includes an individual who's resided in an emergency shelter or a place that's not meant for human habitation, or who is exiting an institution, so for instance, prison or even a hospital. This can include an individual or family who will imminently lose their primary nighttime residence. It can include unaccompanied youth or families who have children, as well as youth who are defined as homeless under other federal statutes. It can also be any individual or family who is fleeing or attempting to flee domestic violence, dating violence, sexual assault, and so on. And so when we think about these particular categories, that sort of sets the context for a couple of the slides I'll be sharing with you next. So according to the National Alliance to End Homelessness, there has been a general downward trend in the rate of homelessness in the last decade. So since 2007, there's been about a 15% decrease in the rates of homelessness. However, we are starting to see a slight uptick in the rates of homelessness. Between 2017 and 2018, there was about a 0.3% increase, which equates to approximately 1,800 people. When we look more closely at the data, however, we see that some groups have done better than others since 2007. And so veterans have, by and large, done the best at decreasing their overall rates of homelessness. They've seen a 38% decrease since 2007. We also see that people in families have experienced a 23% decrease. And then persons who have experienced chronic homelessness also have had a 19% decrease since 2007. Individuals, however, they have only seen, so individuals experiencing homelessness, unaffiliated with families, have only seen a 10% decrease in homelessness. And what's particularly problematic about this is that this population makes up about 67% of the homeless population. And what's more problematic and relevant to this presentation is that this population is getting older. So this trend in the aging of the homeless population has been occurring over the last 30 years as the average age of single adults experiencing homelessness has increased. Estimates suggest that 35 to as many as 50% of single homeless adults are aged 50 and older. However, again, if we think back to those definitions that I shared with you at the beginning that are collected by HUD, there can be some limitations based on the definitions that are used, but also on point-in-time counts, which are how we count the persons experiencing homelessness in our communities. So it's likely that this is an undercount of the numbers of people, older adults who are experiencing homelessness. And so you see the age 50 here, and you might be thinking, wait, Sarah, 50 is so young. Why are we using this age? And so 50 generally has been used to characterize older homeless adults, for one, because of poor mental and physical health that really accelerates the aging process. So the medical age of persons experiencing homelessness exceeds someone's biological age. And as geriatric conditions affect individuals experiencing homelessness, they appear about 10 to 20 years older than their counterparts who are housed. When we look at the poor health among individuals who are experiencing homelessness, we see that this is a result of multiple factors, which include the adverse effects of homelessness itself. So thinking about the exposure that someone has to the elements and to outdoor environments, injury, trauma, and violence that's affiliated with shelter and street life, as well as those who are fleeing violence. Delays in seeking care, which can result from a hesitance to engage in the healthcare systems, particularly those that are not trauma-informed or patient-centered. The spread of infectious diseases that are in crowded shelters, something that COVID has unfortunately really brought to light over the past several months. As a result of treatment non-adherence, whether this is by an individual's choice or whether it's as a result of barriers that people experience when they're accessing healthcare, including the lack of transportation or the cost of healthcare itself, and also unhealthy lifestyles more generally. When we narrow in on the health conditions of older adults who are experiencing homelessness, we do see high rates of a number of particular health conditions: frailty and functional impairment, cognitive impairment and traumatic brain injury, urinary incontinence, hearing and visual impairment, as well as arthritis, hypertension, diabetes, and asthma. So you can see there's multiple health conditions here. And what's more, these physical health conditions are complicated by comorbid substance use, mental health disorders, including depression, anxiety, and experiences of post-traumatic stress disorder. And so given the health complexity of the population, one of the troubling issues that we're confronted with is the expected growth and the continued growth of older adults experiencing homelessness over the next decade, as has been forecasted by Dennis Colhane and his colleagues out of the University of Pennsylvania. In their study, they suggest that it's really the younger baby boomers, so those who were born in the 1955 to 1964 years, that are disproportionately likely to experience homelessness. And so this is recognized by Dennis Colhane and his colleagues as a cohort effect, so whereby those who were born in that second half have been at a greater risk of homelessness at some point in their lifetime, over their entire lifetimes. So more specifically, when this group came of age, there was already competition in the labor market and the housing market, which was flooded with the older baby boomers, so those who were born between 1945 and 1954. So employment, wages, and employer pension programs were down while housing costs were up. They then were faced with economic recessions in the 1970s and 1980s as individuals were entering these markets, sort of thought of as the prime of their life. Further, in the 80s, there were cutbacks to the social safety net programs. We can think about Reaganomics. Reagan was famous for saying that homelessness was a lifestyle choice, and this was reflected in the social policies of that time. In 2008, there was the 2008 foreclosure crisis where many people lost equity in their homes. And then today, what we're seeing is the impact of COVID. Already we're seeing significant impact on job loss. We're seeing budget cuts. And while there had been some moratoriums on evictions, we're now seeing those moratoriums on evictions come to an end. And so the impact that COVID is going to continue to have, not only on the older adult population, but thinking about the life course impact of many of these issues is yet to be seen, but I would predict to be quite damaging. And so in addition to COVID, I think something that we need to bring to this discussion is something that's playing out, as a result of the murder of George Floyd and many other Black Americans. And so in addition to these cohort effects that have impacted younger baby boomers, there's also been discriminatory and predatory practices with Black and Native populations that have had devastating consequences for their ability to accumulate wealth. And though this isn't the focus of what I want to talk, what I will be talking about today, I would recommend people to look into some of these policies. So for instance, redlining that has occurred in Salt Lake City and in other urban centers around the United States. And so recently, the Salt Lake Valley Coalition to End Homelessness, which is a coalition that anybody can join and that I'm part of, they shared an analysis of some data from the Salt Lake continuum of care, which analyzes the homelessness management information system data. So they looked at a time period from July 1st of 2018 to June 30th of 2019. And they found that among Black or African individuals, they made up 13.1% of those who are receiving homeless services, but they only make up 2.2% of the total population. So this population is nearly 6 times larger than what we would expect to see based on the county's demographics. And among American Indian or Alaska Native individuals, they make up 5.2% of those who are receiving homeless services, but only 1.4% of the total population. So it's about 3.7 times larger than what we would expect based on the county's demographics. And so just something to think about and to contextualize how the pathways that individuals have into homelessness. And so I'm going to switch now back here to focus specifically on homelessness in later life, but hopefully you can appreciate that there are many pathways that can result in homelessness. And some that I want to re-highlight here are rising rental costs in a world where older adults have little increases in their fixed income, particularly those who rely solely on Social Security, and about as well as issues around limited, affordable, and accessible housing, and thinking about whether people can age in the right place, whether their mounting health issues make it challenging for them to remain in their homes, or if they have to move, and whether where they're able to move is affordable for them. financial insecurity that people experience as they age. And this is particularly the case for older women who have had life courses where it's been more difficult to accumulate wealth so that they're secure in later life. And then hospitalization as one pathway into homelessness, particularly for those who have extended stays in hospitals and are challenged to afford their housing costs as a result. And you can open the newspaper these days and see some of the costs that people are incurring as a result of hospital stays related to COVID and the detrimental impact that this is going to have on people, particularly those who aren't insured to cover those costs. I also want to think about the experiences of homelessness in later life as broadly being two separate groups, though there's a lot of overlaps in here. And so on the one hand, we can think about individuals whose first experience of homelessness was before the age of 50. And then there are those whose first experience of homelessness was after the age of 50. So among those whose experiences were prior to age 50, you'll see higher rates of childhood trauma and abuse, mental health and substance use disorder, lack of spouse, partners and social support, low socioeconomic status, underemployment, and incarceration. Among those whose first experience of homelessness was after age 50, it's slightly different. And so this group actually makes up about 44% of older adults experiencing homelessness. And so these individuals are characterized by having experienced health or financial crises in later life that have led to their becoming homelessness, the breakdown in relationships or the loss of loved ones, trying to manage on fixed incomes, and the loss of the ability to work. So you see that these are slightly different groups and multiple pathways into homelessness. Now let us sort of set the stage with the research that other people have done. What I want to do is share with you some of the research that I've been engaged in. And as Dean Teasley mentioned, while I'm relatively new to Salt Lake, and the research I'll be sharing with you was conducted with communities in Vancouver, I think what you'll see is that there's many of the same themes that we can apply to our area in Salt Lake. So in the first study, what we did is we focused on Housing First. And this is, if for those who aren't familiar, this is an evidence-based model. It's based on a great deal of research that even includes a 5-year randomized control trial. And so this model focuses on the provision of permanent independent housing while concurrently providing support services. So these support services are really recognized as essential for Housing First to be successful so that it can support individuals to remain housed. So you can imagine, for instance, that staying housed or staying indoors might be difficult for those individuals who have had chronic experiences of homelessness, from being able to pay their bills on time to cooking nutritious food or keeping their home clean. All of those can be challenging without the right amount of support or wraparound supports. And so some of the goals that are going to be important to mention at this point is that Housing First really aims to provide consumer choice, so people have choice in where they live, as well as immediate access to housing without any prerequisites. So as opposed to models that were in place in the the early 2000s, where it was treatment first, where the idea was that you have to go to substance use treatment and then you access housing. This really flips that on its head. And so there's no requirement that people are sober or go to treatment prior to accessing housing. And a second goal of Housing First is really to support clients' reintegration into the community. And so making sure that they're part of the community. However, in this randomized control trial and in this evidence-based work, there's been little focus on how this model supports older adults specifically. And so now, based on what I've already shared with you, we know that it's a unique population. And so for this study, what we really looked at what were the senior-specific needs, challenges, and resources that enable Housing First. And so much of my work is aligned with community-based participatory research. We collaborated with representatives from the Greater Vancouver Shelter Strategy, as well as BC 211, an information and referral service. And these partners were integral to the decision-making and informing all stages of the research. And we conducted deliberative dialogue workshops with providers and older adults. So for those who aren't, just briefly, those who aren't familiar with deliberative dialogues, these are really workshops that aim to create platforms where diverse perspectives can be shared and really generate ideas and solutions. And so in our 4-hour workshop, it had 3 different activities. So the first activity, we engaged in a case discussion where we identified key issues and specific services that would be needed by hypothetical older adult clients of HousingFirst. Second, we used community mapping activity, which served as an interactive method for participants to describe how the resources were both distributed and how they were used across the region. And then finally, we engaged in a magic wand activity, which was used to elicit housing-related support services that the participants perceived as lacking but necessary. And so a number of themes, 7 themes emerged from our analysis of that workshop data. So in a moment, I'll list them here, and then I'll go through each of them and provide a little bit more context and a little bit more detail to those. So of the supports that participants reported older HousingFirst clients needing were housing, home support, transportation, and information. And some of the particular challenges were finances, cultural diversity, and discrimination. And as in most research of this kind, when we're looking at homelessness and housing, in order for HousingFirst to be successful and to be sufficiently support program participants, there is a need for adequate housing. And particularly when we look at older adults, there is a need for adequate housing across the continuum, all the way from subsidized independent housing, supported housing that can bring off-site supports on-site, as well as assisted living or permanent supportive housing where you see on-site supports provided already, and then to long-term care beds. And as one of our participants in that workshop stated, we have long-term care, which is totally inadequate and unaffordable. There's long wait lists and the conditions are not up to the normal standard for living. Participants also described the challenges with what we call renovictions, whereby tenants who are living in affordable housing units are evicted on the basis that there'll be these large scale renovations and they won't be able to move back into their prior homes. They're essentially priced out of the housing market and they need to find homes outside of their community. So really uprooting people from their homes and their community. Participants also reported the need for in-home support. So this included community-based medical and social programs, caregiver respite support, social programming for isolated and homebound seniors living alone. As this participant stated, the most important service for seniors is medical follow-up at home, and we do a very poor job of that. It's difficult for the majority of my clients to make appointments and then actually get there. And so related, participants emphasized the importance of low-cost transportation services. And so while transportation for clients who need to get to medical appointments was a priority, there was also a reported need for transportation to help seniors' socialization needs, so that it's not all just about their physical health, but it's also about their psychosocial health and well-being. And as one participant stated, transportation services were only covered certain areas, which left certain clients out of that service area with very few options. And in Vancouver, it's known as Handy Dart, but in Salt Lake, it's the UTA paratransit. And so this is for passengers with physical or cognitive disabilities who are unable to use conventional public transit without assistance. And so here, even the participant states, even to order Handy Dart, you have to order a certain number of days in advance. You can't order it ongoing or recurring. And it can be really confusing for anybody, especially a senior who has any kind of cognitive impairment. It's really a barrier. Participants reported that information services are needed to appropriately support older adults. And while this includes online resource lists, there are a number of challenges with online resource lists. They don't adequately capture access details. So for instance, what is the wait list for a certain service? What are the hours of operation? And what are the program eligibility criteria so that clients can access these services? There's also a lack of assistance in completing forms, which is a significant barrier to accessing resources. So having an individual, a caseworker, a case manager, help people complete forms was something that was reported as needed. And then related to this was the challenge that clients without English language competency or adequate education have when they are also looking to complete application forms. Finances were also reported to be a challenge for seniors who are living on limited income and who are going to be unlikely to pay even a small fee for services. So for instance, if there's a choice that an individual has between paying an entrance fee for a social program at a community center or having money for food, the answer is quite simple. They're gonna probably pay for food. And a related challenge was that clients often have disorganized financial records, which makes it very difficult to assess the resources that individuals would be eligible for, that would be available to individuals who would meet certain low income eligibility criteria. And as this participant states, unless the finances are sorted out, it becomes a real barrier to finding services. Because accessing any of the private ones, even subsidized, they don't want to touch you until your finances are sorted out. Immigrant and refugee seniors were identified as some of the most vulnerable groups, though they don't often present as clients. So settlement worker participants reported that immigrant and refugee seniors make up a group of invisible older adults because they sleep in people's different homes and they don't show up at service agencies. It was reported that many of the immigrant and refugee seniors are not eligible for subsidies for social assistance because they don't meet the eligibility criteria, and that language barriers and lack of knowledge can prevent them from even seeking appropriate services in the first place. And so participants who worked in mental health and substance use fields also reported this lack of cultural diversity among their clients, as the referrals were not being made by members of certain cultural groups. This one participant here states, it's not that they're not there, but we're not getting referrals. Chinese and Punjabi population also have even more intense stigma around substance abuse. And finally, the final theme that we found in this study was that of discrimination, and particularly in healthcare settings. So for example, some physicians were reported to not serve clients who have multiple and/or complex mental and physical health issues. As this participant here states, general practitioners don't want to take our clients because they have too many problems and it's complex. If you're too sick or have an issue, they aren't willing to take you. And so as we think about Housing First as an appropriate model for older adults, by and large, participants suggested that there's work that needs to be done, and that it may not be a viable model for older adults without some certain tweaks to better fit this very unique population, though it is evidence-based with the broad general population. So first, the challenges with the limited affordable housing. It limits clients' choice, which does not align with the Housing First principle of consumer choice, and the lack of housing also does not align with immediate access to housing. So people are having to wait to access housing. Second, with older adults having to relocate to new communities where there is affordable housing, they lose those social connections, which further isolates older adults rather than reintegrating them into the community, which again is at the core, which is a core tenet of Housing First. And then finally, in some Housing First programs, there's a requirement that clients are chronically or episodically homeless prior to receiving Housing First supports. But this is a huge barrier for those older adults who instead are going to be newly homeless and not meet that eligibility criteria. And so just to sort of wrap up this first study that I wanted to share with you, we can really think about the need for shelter and housing across a continuum from emergency, temporary, and transitional settings where there are medical supports for people independent housing that has off-site supports that can be brought in, supported independent housing, permanent supportive housing, long-term care, and palliative care and hospice. I'm going to quickly move here to the second study I want to share with you today, which is about the health and psychosocial supports that are needed for older adults who are experiencing homelessness upon hospital discharge. And so while we've been talking about this, homelessness has these direct negative effects on people's health, and compared to the general population, persons experiencing homelessness have these disproportionate burden of both acute and chronic illnesses and higher rates of mortality. And as a result of limited access to healthcare, as well as limited use of primary healthcare, the main point of entry into the healthcare system for homeless adults is often hospitals and emergency departments. And when persons experiencing homelessness are discharged from the hospital to settings where they aren't supported or they're unable to continue recovery or adhere to follow-up care, it can be costly not only to the healthcare system, but also to an individual's health and to their quality of life. However, the research that really looks at the health supports needed for older adults experiencing homelessness when they are discharged from the hospital has been limited. And so we conducted research. And again, my work is guided by the principles of community-based participatory research. And in this study, we conducted interviews with shelter and housing providers and healthcare providers and conducted a thematic analysis. And before I get to the themes, one of the quotes from this study that always stood out to me, it is really just that in general, just as we're seeing with the quantitative data from other research, participants are really highlighting the significant growth that they're witnessing in the number of older adults who are experiencing homelessness. So this wasn't a theme that we focused on, but this was something that participants were talking about in this study. And so for the first theme here was really the unique vulnerabilities. So participants reported that compared to younger persons who experience homelessness or to age-matched counterparts who are housed, older adults who are experiencing homelessness have these significant and complex health conditions and unique vulnerabilities as a result. So this participant states, one thing we've noticed as people age, and it's not even all that old, 40 to 60, the chronic disease starts to mount and their illnesses start to mount and they can't really manage independent living. The second theme is the inappropriateness of general population shelters for older adults following his hospital discharge, largely a result of their complex and chronic health conditions such as mobility or incontinence. So we can think about design limitation challenges for older adults who can't mobilize, who can't transfer unassisted. There's operational rules that create barriers to older adults' ability to rest and recover. So for instance, shelters that close during daytime hours, or beds, shelter beds that are only available on a first come, first served basis, as well as shelter staff who may not have had medical or personal care training, because that's not part of their training. And so this participant here speaks to some of the vulnerabilities that older adults have in shelter settings. You have a frail 70-year-old being discharged into a shelter with a lot of young people where this 70-year-old can be rendered very socially and economically vulnerable. The third theme here is the limited availability, again, limited availability of shelter and housing options, particularly for older adults who have complex health and social needs. And so though some shelters were reportedly able to partially accommodate the health challenges experienced following discharge, there is a high demand for the beds that accommodate those needs. And so that makes discharge planning very challenging for individuals. And so this healthcare provider stated, I have to call every morning, hey, do you have a shelter bed for a patient who needs a bottom bunk and no stairs? And a lot of these shelters will have 6 beds, but they're always full. The fourth theme here highlights the need for shelter or housing that's tailored to different groups of older adults. So both the first time persons experiencing homelessness for the first time because of limited income or unaffordable independent living, but also those who have experienced chronic homelessness, including those who have concurrent disorders of severe mental illness and substance use disorders. So here a provider states, With the seniors population, a lot of these guys don't fit into the shelters, but they can't get into independent housing because they don't have enough money. They can't get into assisted living because they're alcoholics. And then a lot of the seniors homes here, they don't support folks who've got alcohol issues or brain issues and dementia coupled with substance use. So there's no support for these guys. What happens is that really the only option is a shelter. A fifth theme here is that there's a need for unique community supports following hospital discharge for older adults. So for instance, there's a need for check-ins or assistance performing activities of daily living and instrumental activities of daily living. There's a need for medical support, such as vision, dental, and nutrition. There's a need for mobility support, such as arranging for equipment or transportation. Here are provider states. A lot of people don't have skills around the activities of daily living. Some do, but for the most part, certainly men don't have a lot of skills around how to function to keep themselves fed, cleaned, and their four walls in good shape. So they really do need support around that. And then finally, participants describe the need for medical respite beds following hospital discharge so that individuals can continue recovery and rest. And this participant states, it would be awesome if there was a place that would put people from the hospital so they can heal and have medical attention before they're deemed able to live independently. And so there is some good news. There is a program many of you may be familiar with. Medical respite broadly is thought of as an evidence-based model that provides post-acute medical care for people experiencing homelessness who are no longer ill enough to justify staying in a hospital bed, but they're really too sick or frail to recover on the streets or in a traditional general population shelter. And so the first medical respite programs were developed in the mid-1980s in the United States, and now there are more than 200 healthcare for the homeless programs that have been integrated into the US federal healthcare system. And so some of the great outcomes that we see from medical respite are improved health and reduced healthcare costs, medical stabilization and improved quality of life, access to health and community care, and increased access to income and housing. So when people have a chance to rest and recover and be connected to services after being discharged from the hospital, as opposed to being, discharged to the street or to a shelter setting, there have been some really great outcomes shown with that model. And so I'm going to sort of wrap up here with some broad implications for both policy and practice, and then for research. And so these are the things that I think policymakers and practitioners need to consider as they think about services and environments that impact older adults, and they're making decisions for older adults for whom they're providing care. So thinking about the physical locations, such as shelter and housing, needing to offer services and supports, and taking that HousingFirst model of wraparound supports and medical respite model of wraparound supports in order to help empower people to move on. Social supports through facilitating peer networks, and again, empowering peers to support one another. There's been a lot of great work done on building peer networks. Embedding cultural safety in service considerations. We see a lot of trauma. We see a lot of mistrust of the healthcare settings and other social service settings. So really embedding cultural safety and trauma-informed practice into what we're doing to serve clients. Removing procedural barriers to accessing services. So there's a lot of rules and regulations out there that really prevent people from accessing services that they're eligible for, and that could really help them so removing those procedural barriers sort of from the outset. And then at the institutional level, really eliminating these structural, ageist, racist, and what I call homist practices that are embedded within the systems and in the institutions that provide care. And so as I think about what some of the next steps here might be for research and where I'd like to go, and I invite anybody who's interested to join me on the journey. As Dean Teasley mentioned at the beginning, we're starting some new work around aging in the right place, and not just thinking about older adults aging anywhere, but really focusing on what is the right place for people, and it's going to be very individualized, but we'll be doing some evaluations of shelter and housing models, and how and what ways they support older adults who have had histories of experiencing homelessness. Hopefully be doing some work increasingly on transportation so that we can think about the access that people have to services and supports in dispersed geographical regions such as Salt Lake. I want to explore, or I've started to explore even this idea of homism, which we really look at the intersection of prejudice and discrimination based not only on race, not only on gender, and not only on age, but really based on the experiences of prejudice and discrimination based on someone's housing status. And then lastly, looking at ways to prevent evictions from the outset, really having an upstream response to homelessness in later life. And so I thank you all for your attention and your time. I really encourage you to use the Q&A feature for the webinar to ask any questions. I'd be happy to do that now, but anytime, please feel free to connect with me. I've listed my email here. You can find me on Twitter. And then I also have a ResearchGate page where some of my articles are listed, and you can just quickly request them and I'll send them off to you. And then as I close today, I just want to, again, sort of refocus us back on some of the very critical issues that lie at the core of housing insecurity and homelessness, and forefront here some amazing work done when we look at the intersections of racism and housing insecurity. So I would encourage anyone to, I have references after this as well, and I'll share these slides, but I encourage you to dig deep into some of these resources and to look at those really important intersections of how we have developed a system that at its core is racist. So I will stop there and try and come back to you all. So I will stop sharing. Okay, so I see a couple questions. Let me just see. Okay, so one question here. Thank you for the questions. I would also imagine that many older adults are not necessarily computer literate. Absolutely. So we can think of this, the term that we hear a lot is the digital divide between those who are able to access resources and not. So one of the things that's really key here are individuals. And so we can think about not only peer networks, so a sort of peer-to-peer education and connection sort of by word of mouth, but really embedding caseworkers, social workers, case managers to connect people to the services. So it's a lot of outreach. It's a lot of, I mean, it is a human world. So essentially we need to connect people from the outset with the technology, or really to help assist in completing forms for them. So I think that was more of a comment, but I'll just, there wasn't a question there. Where is medical respite offered in Utah and who pays for it? That's a great question. So within Salt Lake City, and I would encourage anybody else who knows more about this than me to please comment as well. But within Salt Lake City, there's two programs that I'm aware of. One is the 4th Street Clinic, and I don't actually know who pays for it, but I imagine that they could probably tap into some of the help, federal dollars. There's also an amazing hospice model in Salt Lake called the In-Between. And so I also don't know who pays for that, but maybe someone else can provide some information as we're talking here. But those are two models in the Salt Lake area. Broadly within Utah, I apologize, I don't know outside of Utah what else is provided. But there is a National Healthcare for the Homeless website that lists, that has a huge listing of them all. So I think the primary one in Utah would be the 4th Street Clinic. What does Utah have medical respite shelters? How full are they? Can someone discharging from a SNF be sent there, and for how long can they stay? So medical respite is really thought of not as a long-term solution for anyone, but is much more of a transitional location. I don't know offhand. Again, this would be sort of a 4th Street Clinic specific question about how long someone can stay at a medical respite. I imagine that there is a long waiting list for these services, which are in significant need. And so we can even think, oftentimes when I do this talk in person, I ask people to kind of raise their hand, and say, who here who has been sick before, who has ever been sick, and where do you go when you are sick and, you leave the hospital? And many people are fortunate to have a home and they can go home and recover there. And so this is, it's an issue that I don't think enough people are focused on or paying attention to, but there's a significant need for it. Can someone discharge from a SNF be sent there? So can someone discharge from a skilled nursing facility? I think that a skilled nursing facility actually would be providing the same type of services for that a medical respite would. So they're very similar models, but SNFs are have potentially not been developed for the sole purpose of serving individuals who have had experiences of homelessness. So I think they serve different populations. So I'll stop there because I don't know anything else about that. What guidance would you provide to the communities that are reluctant to have medical respite housing for homeless in their neighborhood? Yeah, I think that's a great question. How do we as a community in Salt Lake come together and recognize not only medical respite housing, but we have new resource centers that are no longer at the traditional road home shelter at the downtown location, but have been spread out across the region even further. And there has been what we think of as not in my backyard, NIMBYism. And there are some really, I think, grassroots movements looking at ways to flip that and do YIMBYism. So yes, in my backyard. And I think it's a matter of telling the story that these are humans who are in need of care. And we're a community, and to come together as a community and really, I think, changing the dialogue and changing the language of what being homeless is. So I think a lot of those who work in the homeless sector and have had the privilege of working with people experiencing homelessness, we see the amazing stories, the amazing resilience, the positive outcomes that can happen through connection to the right type of service, not any type of service, but that culturally and trauma-informed service. And so really, I think telling the story, and if we're sharing people's story, I think we also need to pay them accordingly. So I don't think that people just have to tell us their stories and re-traumatize themselves every time they're telling a story. But I think it's really important for us to recognize the need to compensate people for sharing their story. So I would love to sort of work on any kind of like media reframe of how we view this discrimination and prejudice against people. So thanks for bringing that up. James Brown, hi James, great to see you here. So this seems to be a perfect time to create a universal concept of reacting to this problem of homelessness. What do you think this concept would look like? Whew, that's a great one. Yeah, I would love to talk more about that. I think, so I've been really working on this idea of prejudice and discrimination and stigma against people, as a concept that's separate from our traditional ideas of racism and sexism and ageism. And I think, when we first, you know, as I'm trained as a gerontologist, when we first started thinking about prejudice against people who were older, you know, the concept of ageism wasn't even a term until the 1970s. There is no term for the prejudice and discrimination that people experience based on the lack of housing. So as an individual, I just made up a term and I started using it, and I call it homism. And I think by beginning to name it, it is a thing, it is a concept, it is an experience that people have. Maybe then we can start engaging in dialogue about ways to address homism, or the prejudice and experience of discrimination against people based on, and it doesn't have to be just the lack of housing. We also discriminate people based on the type of housing they have as well. So I would love, James, let's keep that conversation going, because I think that that's really important to sort of shift this cultural narrative that we have about homelessness and people who are homeless, you know, who are people, who are humans, who are our neighbors as well. So thank you, James. On a functional level, how do you help seniors who have these housing, medical, and care needs when the resources are not available? How do I bridge the gap between the lacking system now and the needs that are already here? I know I have met several seniors that need inpatient hospice care, and there's, yes. So what do we do in a world to help people who have these needs, these very complex housing, medical, social needs, when there aren't resources available? How do we bridge the gap between what's needed and what does not exist? Oh, I don't know. I think one of the things that, I mean, I think would be great, I mean, I know we have someone from Aging and Adult Services here. I don't know what the network, how we share resources how well rather we share resources in Salt Lake, and whether there are enough connections between you being able to know, Clarissa, what the available services are. I know I've met several seniors that need inpatient hospice care, and there's, yeah, and so, for instance, if you're looking for hospice care, I'd be curious, like, where do you go to look for that? And is there availability, and are the wait lists quite long? I think that would be something that's seen a lot, and it takes advocates, actually, so that those who do better in the systems that we have advocates walking alongside them, and continuing to call people, continuing to advocate for their needs. So if you're doing that work, thank you, because that, I think, is how people are going to best access the resources when we live and we try and function in such a limited resource poor world. So I don't know, but I encourage people to yes, share resources, and I'd love to connect later. Elise, hi. What needs to be done to socially integrate older adults? Does this duty tend to fall mainly on care providers? I don't think so. This is a great question. So what needs to be done to socially integrate older adults? I think in communities, we and we think of we think of providers as maybe our first line, but actually providers are really overworked. They have a lot to do. They have paperwork, they have systems that they have to follow, they have other clients. In our communities, there is a whole wealth, a whole resource of individuals who are untapped. And I think that's older adults and people with lived experience of homelessness themselves, is like, how can we build peer networks? How can we build capacity among those who have the experience and have the knowledge, and rely on those resources to help integrate people, and sort of act as an additional line of outreach, so that we can reach out to those people who are you know, in need of integration. So I'm just at time, so I'm going to wrap up there. I do see one more comment I will just make real quick, which is that the in-between has, that I mentioned, which is the hospice location has about 10 respite beds, and the rest of the beds are for individuals who have a terminal diagnosis of 6 months or less. And that waiting list is very long. So thank you, Danny, for that additional information. I'm sorry I couldn't get to the other questions, but thank you all for joining us. And please do stay in touch and reach out to me if you want to have any additional conversations about this topic. So I thank you all for your time and wish you well.